share best promising practices. It's important to us at NCCID that we think very explicitly about the needs of First Nations, Métis, and Inuit community experts and leaders as part of those populations that we're thinking of, and looking for where systems and structures can be changed to improve health equity for all. Next slide. Sorry, next illustration, not next slide. So overarching, stop here. All of this is that we work within the framework of the Sustainable Development Goals, which were ratified by the United Nations in 2015. Many of you will know that there are 17 Sustainable Development Goals, which were ratified by all 192 member states. And their primary aim is to leave no one behind. That's the way it's stated. The international ratification of the SDGs signifies aspirations and commitments to collective action to improve the health, the rights, and dignity of the world's populations while sustaining our shared home. If you look at Canada's federal website on its commitment to the Sustainable Development Goals, it encourages action on the SDGs in every institution. And the 2030 National Agenda Strategy for Canada notes the need for whole of society approaches. So reaching the furthest behind first, including, and here it's specified under Objective 4, reconciliation with, by, and for First Nations, Métis, and Inuit peoples. So really just to say that this is part of the framework of how we came at this work, which we started just a year ago. Thanks. And Susan, I'll turn it over to you.
Great. Okay, thank you, Margaret. So as Margaret said, NCCMT came into this project to undertake a rapid scoping review. And the question that we were asking of the literature is, what is known about the role of public health in working with shelters serving people experiencing homelessness? So this was a rapid scoping review, which is a kind of systematic review, but a scoping review is done when we are looking to see what's out there, what's known in a field. But we were not in this kind of review looking to explore how effective the interventions were. We didn't assess the quality of the research or the strength of the designs. Our purpose really was simply to take a wide net and just see what the published literature and the gray literature could tell us about this question. So on the next slide, I'll say just a little bit about how we actually went about doing that, what the search strategy is. So Alana, you can go to the next slide. We used 3 main sources, so Medline, Ovid MCare, sociological abstracts. We also looked to gray literature, although we actually did not find anything to include in the gray literature. On this, for this particular search. So we laid out the search in terms of the population that we were interested in, so people experiencing homelessness who use shelters, but also people involved in shelters, so staff, medical personnel, volunteers. The concept was, of course, partnerships, relationships between shelter staff or shelter organizations and public health personnel or organizations. And I'll say just a little bit about what we meant or how we ended up defining public health personnel, because that was actually one of the challenging pieces of doing this rapid scoping review. Because the purpose of the review was to understand what was published in the field fairly broadly, we weren't really rigid about what public health meant. So we included any partnership on a public health related topic that could have included public health agencies or public health staff. So even if the specific source that we were looking at didn't identify that these people, this organization was a public health organization. We went more in terms of the nature of the topic. So for example, infection prevention and control interventions that were implemented in or with shelters might or might not actually have been implemented by public health agencies, but because it could have been implemented by public health agencies, we included it for the purposes of this review. So the people involved didn't necessarily have to work for a public health unit or department, because in many cases that simply wasn't clear from the literature, because that wasn't the purpose of the articles. But it had to be on a public health topic that potentially could have been delivered by public health. So, and then to the next slide, let me tell you what we found. We found 52 sources to include, so 11 systematic reviews or syntheses and 41 single studies. And you can see the topics that were represented. Most of the single studies were observational, so including descriptions or evaluations of programs or approaches taken. There were, though, some experimental designs, trials. 14 of those single studies were of that sort. So that meant that there was a specific intervention implemented and then studied for research and learning purposes. So perhaps a more intentional research side as opposed to a description of just a program that was happening. If we go to the next slide, I'll say a little bit more about the topics that we found. And this was really one of the major purposes of this scoping review, was to describe what kinds of partnerships have happened between shelters and public health. So there were a good number related to dental or oral health. So things that provided oral health assessment, referral, treatment, education. And one comment that I'll make about this is that many of those were dental or oral health assessments. And in order for that to be a really valuable intervention, you would have to find a way then from those dental health assessments to actually providing treatment, follow-up care, and so on. So the fact that we're finding these descriptions of programs that provided dental health assessment doesn't necessarily mean that there was treatment available to follow up, kind of that kind of piece that would be so important. We also don't know that the dental providers would have been sensitive to the needs of people experiencing homelessness. So there are lots of unanswered questions, but at least in terms of some partnerships, there were some related to dental or oral health. Infectious diseases, the candidates you would probably think of in that regard. And some related to mental health and substance use. So 3 of those related to tobacco cessation. And one of those was actually public health working with shelter staff to build capacity about the smoking cessation programming. Most of the other examples were public health working more directly with shelter clients. But there was this one example of working with shelter staff. And health promotion programs, so vision care, nutrition education were other topics. On the next slide, I'll say a little bit about the approaches. So we have those topics, but what did they actually do? How did they approach that sort of public health work that was done? A really broad range of the kinds of things that we do in public health. So prevention, screening and testing, some health promotion and education, harm reduction, infection prevention and control, of course, outbreak management, immunization, treatment, capacity building, policy development. So one of the takeaways is that there's a really broad range of the kinds of services or approaches that public health does in general in these partnerships or working with shelters. On the next slide, one of the other pieces that we wanted to look at was, what is the nature of these partnerships? How did public health and shelters actually work together? Well, in what we found, there was kind of a continuum from what I would call one-offs. So these would be mostly driven by public health or public health researchers. So for example, recruiting research participants from a shelter. They show up, they say, can we do this together? And that's pretty much the extent of it. And then kind of all the way along that continuum, you can find examples right up to fairly elaborate multi-partner collaborations that are often co-created, long-term, sometimes client-driven collaborations that come out of multi-partner initiatives with public health, shelters, other community agencies, individuals experiencing homelessness as well. We see some examples of that. So lots of examples anywhere along this continuum, from the one-offs to those much more elaborated multi-partner collaborations. So one of the other things that we do in a scoping review is look for what's not there, what's missing. So if we go to the next slide, I'll just comment a little bit on the limitations of what is present in the literature right now. No doubt there are partnering experiences that don't find their way to publication. So there's lots going on that doesn't show up in journal articles or even in the great literature that we looked for. Another way of saying that is that there's probably a publication bias at work, so that we don't hear things about partnerships that are not successful. Those are less likely to be written up. And we're probably missing some learnings from partnerships that were really effective, but just didn't get written up in the research literature that we could then find in our scoping review. Another gap is about specific populations and equity considerations. Certainly this literature was about partnerships that in some way involved or affected clients experiencing homelessness. So that is one equity deserving and a specific population. But within that population, we don't see a lot of commentary about particular populations. So Indigenous or racialized communities not explicitly represented very much in the literature. And so there was one Toronto-based example of a project that worked specifically with Indigenous people on some public health topics. But in general, although Indigenous clients or racialized clients may have been represented in the populations of other examples that we looked at, there was nothing really specific said about ways to work effectively with those populations or what the needs might have been. One study of services at a shelter for women experiencing domestic violence talked obviously specifically about women's experiences, but again, women's experiences are largely absent from the descriptions in the literature. Women may have been shelter clients. In fact, in some cases, we know that they were, but their particular experiences are not highlighted. So all that to say, I would highlight that there's an opportunity for the research literature in this area to be more intentional about equity and serving or addressing the needs of specific populations who live with social and structural inequities. There's also not a lot of specificity in the literature about specific types of shelters. So although we know that these are either shelters for women experiencing domestic violence, a small proportion of them, or a larger proportion of studies of shelters serving people experiencing homelessness. Beyond that, we don't know a lot about the specifics of, what kind of shelter or the specific ways that they worked. So lots that we found in this scoping review, but also some gaps still to be addressed. So to sort of wrap up my piece, if we go to the next slide, and I'll just highlight some of the takeaways. There is a variety of topics, approaches, and models of care or ways of partnering between shelters and public health. Really, covering the gamut of what we might expect to see in terms of public health sorts of approaches and topics. When we think about those partnering examples that were more involved and more elaborated, it's not a surprise to learn that by following good public health engagement practices that we use in our practice often, that those also created some really good, solid partnerships with shelters and shelter staff. So, the way to strong collaboration is by using those longer term relationship-based engagement strategies. Some of the examples of the more collaborative models sometimes also included people experiencing homelessness. So those projects were more driven by their needs than by public health just sort of showing up and deciding what would be offered. So, as you get more engagement, you get more opportunity to co-create, work alongside individuals experiencing homelessness. Not all the examples were like that, but there were some. And as I mentioned, there's an opportunity for more intentionality about equity in this research literature. There certainly are some gaps in our knowledge about how shelters and public health might be partnering to contribute to more equitable service and more equitable opportunities for health. So that's a quick run through the review. The review is available on our website at nccmt.ca if you would like to take another look at that. But I'll pass over now to Adina to talk about how some of this led to or fed into the larger project of engagement with shelters.
Terrific. Thanks so much. Hi, everyone. I'm very excited to be here. Thank you, Margaret and Susan, for Margaret for setting the stage around the project in general, and Susan for providing a really wonderful overview of the rapid scoping review. So now I'm going to talk a little bit sort of how this all looked in terms of our engagement with shelters and public health through the Shelters Project, as well as through the Winter Institute. So, as Margaret said, we really wanted to, the intention was to root this work really from the needs of shelter staff, volunteers, and people who use shelters. So one of our first steps in terms of sort of moving forward in this project was to engage with shelter leadership from the region. And the region that we were looking at was Manitoba, Saskatchewan, Northern Alberta, and Northwestern Ontario. So a region that often is not part of Canada, that's often not reflected as much in literature or in national reviews. So we really wanted to sort of highlight the work and the needs in this region. And Susan had talked about sort of the challenges of defining public health. And as well, it's sort of difficult to define shelters. And we didn't want to, sort of have a set definition of shelters. So one of the first stages, sort of before reaching out, was to look at the scope of what shelters are out there, what services for people who are experiencing homelessness, houselessness, what's happening in this region. So we created quite a broad database of organizations and shelters and services. And then we sort of looked through about who to reach out for sort of our initial engagement process. And we identified 35 shelters in the region to contact, sort of with an eye to sort of types of shelters, regional representation, northern and rural, Indigenous-led organizations, and to sort of really get a broad scope of different services that are being provided. And so in terms of reaching out to the shelters, we made some initial phone calls to sort of identify the shelter leadership, the executive director or program manager, see if they were available to have a quick chat. We followed up with an invitation, and then as well some phone calls and follow-up afterwards. In the end, we had 20 shelter leaders participating in 6 panel discussions, which we felt very happy and really, really touched that people, were made the time to chat with us. And through the sort of exploration of the different shelter organizations, we sort of identified sort of 4 shelter types. So homeless shelters, domestic violence shelters, transitional and drop-in shelters, and youth serving shelters, while also recognizing many organizations provided more than one type of shelter. And those it's much more fluid than sort of siloed, but just sort of get a sense of the different kind of services there are. And each of the panels was by shelter type with cross-regional representation, which we were also hoping that the folks that participated in these panel discussions would also get something out of it, sort of a chance to meet with and share information and discuss with other shelter leaders in a region. And that is actually how it unfolded. There was sharing of information. People wanted each other's emails afterwards to keep conversations going, to be able to provide support. Many folks are working in a lot of isolation with incredible workloads, and so it was great to see sort of some of that connection that was happening between the shelter leaders. So we had 6 panel discussions, each of them, and they were quite small, 3 to 6 participants in each one. As well, we had 2 elders joining us to sort of get us started in a good way and to provide some support through the 2-hour panel discussions. And we asked questions about whether they've had connections to public health, what that might have looked like, some of the key health issues they are seeing in their shelters, some suggestions for working together and how they can sort of envision this process moving forward. And people shared really passionately, really engaged in the discussion. It was really such an honor to be able to sit with these folks online and hear what's happening. We heard a number of different, ranges of partnerships, from no contact at all to sort of more organized, ongoing partnerships. And we really heard that shelters are really on the front lines of healthcare, whether officially or unofficially, and providing a lot of care that they may not have intended to provide, but because of a number of different reasons, sort of are situated to provide that care and to have that trust with their clients. Next slide, please. And at the same time that we were reaching out to shelter leadership, I also reached out to public health personnel in the region. So medical officers of health, program managers, nurses, a number of different practitioners. And these tended to be sort of one-on-one conversations or small group conversations, and similar questions, sort of discussing their experiences working with shelters, what they might see as gaps and opportunities. I guess also the question that was asked both of shelter leadership and public health is, would you be interested in coming to a Winter Institute? Is this something that feels like it's worthwhile, that you're interested in? And we got a very strong resounding yes. So that was also really important to make sure that this was an important topic and process for the people most impacted by the process. So as well, sort of asking about what might be some topics of interest for the Institute, how, what might be helpful for moving this work forward. Next slide, please. And so all of this came together, sort of our engagement with the shelters, our engagement with public health, sort of informed the development of the agenda, the style, the topics, the process of the Winter Institute. We all came together in February in Winnipeg for 2 days, held over 3 days of learning, engaging, discussion. So we had 114 registrants, which include shelter leadership and staff, public health personnel, policymakers, staff from government and community organizations, as well as NCCID staff and staff from the other NCCs across Canada. To come together. And so these are the objectives. I mean, the objectives were really rooted in what would partnership look like, what would be some of the foundational work needed to make this partnerships happen, what are the needs, and what we can do move forward, as well, of course, understanding what are some of the public health and healthcare needs of people who use shelters. And so our format was a mixture of plenary sessions. These sessions were sort of informed, particularly by our engagement with the shelter leadership about what sort of some essential needs and topics of discussion. So the plenaries were for the whole group. As well, there was an opportunity for concurrent sessions throughout the days around maybe topics that may be of more interest in more specific situations or contexts. And as well, we facilitated 3 rounds of small group discussions to really help folks to synthesize, reflect, apply the learnings to what is going on in their communities and their organizations, and to really sort of build that process of conversations and communication. Next slide, please. And so this is just a map of sort of where the different registrants from the who joined the Winter Institute came from. You can see most of the representation is from Northern Alberta, Saskatchewan, Manitoba, and Northwestern Ontario. We also had some folks, of course, from different regions, but the majority were from the region that we were exploring and connecting with. We had fairly good northern and rural representation, which was really important as well. We know that the needs, the context, the realities can look very different as opposed to larger urban centers. Yeah, that's just a little bit of a window of who was there, who came, who was joining in the conversations. Next slide. There was, this was a difficult slide to put together in terms of how to summarize sort of both the process and the engagement that happened at the Institute, as well as, what was shared, as well as what are some sort of where we, where to move forward. Sort of really like represented in the rapid scoping review, we see that there are still gaps in healthcare for people who use shelters, and some of them, sort of some of the topics that were highlighted in the scoping review definitely came up and were discussed at the Institute, including oral care, foot care, mental health, dental, and safer drug use. And so, and as well, sort of access to primary care and acute care as well is definitely a gap for many people who use shelters. Sort of also, what Susan talked about in terms of the rapid scoping review about sort of the essential elements of collaboration. One concept of, the shared approaches to care, particularly cultural safety, trauma-informed care, and harm reduction, were sort of seen and articulated and explored as essential foundations for partnerships, and both shelters and public health working from those approaches, not only in their work with clients, but their work with each other, their work from like sort of system to system engagement, to have all that work to be rooted in that. And, also really hearing about staff burnout and turnover in shelters and in public health, both, areas, sectors that are not always funded adequately and supported enough, and are not often seen as priorities. So that definitely came up a lot through the Institute. And a lot of folks also talked about being at the Institute and being in these conversations was really rejuvenating for some of that experiences of burnout and isolation. And people talked about the experience of filling their cup and some of the, one thing that we heard in the evaluation is that, there was a space to talk honestly about the challenges, but it didn't feel like it was sort of overwhelmingly negative or, unmanageable to find a pathway through. So I think there was a lot of vulnerability. People really came with quite open hearts to talk honestly and openly about their experiences in work and in work with communities. And as well, there was a lot of energy. I mean, the attendees were amazing in terms of their willingness and openness to communicate, to find better ways, and to look honestly at what's going on. I should also mention that we did take a poll at the beginning of the Institute, and 100% of the people who attended indicated that this was the first time that they had been at a meeting like this of connection between shelters and public health. So, sort of really honoring that also that it was sort of a new way to go, and that there was, a strong need to have these conversations. And because there was a strong need to have these conversations, the strong indication of moving forward was that how can we keep these conversations and connections going? The joke by the end of the Winter Institute was, we'll meet again at the Summer Institute, and sort of looking at different ways of what can be supported in terms of future meetings. Are we looking at regions? Are we looking by sector, cross-sectorally? I mean, folks talked about it would be nice for, once again, sort of like shelter staff across the region to have a chance to chat, but then also a chance to have this cross-sector with public health and with other sectors who are providing care for people who use shelters. So yes, yeah, there was great energy at the Institute, and it really highlighted that, shelters are providing this care officially or unofficially, and there's lots of room for partnership, and there's lots of room to move forward to better serve the people who are experiencing houselessness. So thank you very much. Oh, I guess one question, Margaret, is there anything that you would like to add about any of this?
No, thank you, Adina. You covered the points that emerged for NCCID in this partnership together. I guess I would just say, to remind everybody that's taking part in this webinar, that we are just embarking on this multi-year project. So waiting to hear the discussion and questions next.
Thank you so much, Susan, Adina, and Margaret. It's so wonderful to see some focused attention on this important work, given some of the limitations of it. And Margaret, it's wonderful to hear that, as you say, this is just the beginning, and that this is the first step, and really looking forward to seeing how this project evolves. And with that, we will open it up to questions from the audience. If you'd like to put it in the chat.
So while people are thinking of their questions, there is one detail that I'll add that folks may have picked up on already. We did not, at this first gathering, include persons with lived experiences. This was a very thoughtful, difficult choice that we made. And the reason that we, at this point, did not involve them directly in the Institute, they may have been a part of the consultations, was because we didn't want any sense of tokenism, was one reason. And secondly, because the focus overall for the Institute itself was what can we learn about partnerships? So a system to system consideration. Having, I can give you this rationale. There's an even stronger rationale to continue to use to involve, but I was going to say use the voices of, but involve persons who are actually day-to-day using the services of shelters, and that will be an absolute pillar of the work going forward. But for this first institute, and in consultation with colleagues and community experts, that was definitely a gap in what we were able to accomplish in that first meeting.
Thank you for that addition, Margaret. I thought I saw a hand come up. I don't see any
Maybe I can
Yeah.
ask a question if, if others just want to formulate their questions and put them in chat. When we set out to do the rapid review, of course, we're looking to the research literature and using the terminology that's used there to find relevant sources. And so one of the terms that we use, of course, is homelessness. But I know that in your materials and some of your discussion, you use the term houselessness. And I just wonder if you'd like to comment on what is implied, or what the nuance of meaning is with that choice of terminology.
You want to go ahead, Adina?
Sure. Yes, no, thank you for bringing that up, because it's definitely there's definitely sort of some shift that we're seeing in some of the literature and the language. I one of the elders, Leslie Spillett, who worked with the project, I think she articulated it just really beautifully. And so I'll sort of share what she sort of her perspective around this was that, the sense of home can come in a lot of different ways. What we're talking about is sort of more lack of an underhoused in terms of a structure, and particularly she said that there's no way that First Nations, Métis and Inuit people can be homeless on Turtle Island. So that really idea that this is home. So I really appreciated that lens of looking around, looking at the language.
Thank you so much for that context, Adina, and for sharing that. That was actually one of my first questions I had when I saw the title of the scoping review. So that's really helpful. We did receive a question from Christine, who asks, did you have an opportunity to discuss existing barriers to collaboration between public health and shelters, or to shelter clients receiving public health services?
Thank you for that question. Yeah, I think that the short answer is yes. Certainly that came up in the discussions when we asked shelter leadership, what kind of contact connections have you had to public health? What have they looked like? If you haven't had any connection with public health, what does that look like? What's going on? So certainly, there was talk about sort of barriers, sort of maybe more global barriers, as well as some of the more specific, more day-to-day practical barriers. And certainly, shelter leadership talked a lot in terms of the overall barriers to care, and both structural and systemic barriers to care that people who use shelters are experiencing in the healthcare system. And sort of how shelters are stepping in to address some of those barriers, and if and how both primary care and public health could support shelters addressing the healthcare needs of people who may not be able to address, who are facing barriers elsewhere. Does that answer the question, Margaret, or
Yeah,
Susan, would you like to add?
Yeah, I'll add first, Adina, thank you. So thinking about what is needed to set those partnerships, we took a couple of approaches based on what those who work in shelters shared with us and the public health personnel. The agenda for the Institute was a lot about cultural safety, what that actually means, culturally appropriate care, and getting people to think in those terms in a way that was responsive to each other. That was an essential part of how we set the cornerstone. But the other framework that we applied was getting people to think about a settings approach. This is a bit of an old school term, often used in the realm of health promotion. But it really resonated with our public health colleagues to think, oh yeah, okay, so thinking about the setting for the delivery of programs and planning. So there's health care, primary care, and then thinking about public health programs, immunization programs, and the TB screening or STBI screening, for instance. And then the third thing that we integrated in the agenda and probably didn't get into in the kinds of ways that Adina and I first imagined was thinking about or inviting conversation about what is the role of public health to make those connections for the population to primary care. Like, where's that handoff? What does that look like? Knowing that, again, people are mobile, so they're moving in and out of shelters for various reasons. So that's certainly for me an area that I'm looking forward to exploring. So those were different ways that we thought about dismantling the barriers.
Thanks for that additional explanation, Margaret. Sally has a comment, and Sally mentions, when you are ready to expand your work to include people with lived experience, there are some great resources from BC that might be helpful, including what came out of the Compassion, Inclusion, and Engagement Initiative. So we have some wonderful sharing here in the chat in terms of informing your future work. And Bernadette says, hello, so excited about following the progress of this work. There were tremendous partnerships built with shelters in congregate settings during the pandemic to offer COVID-19 vaccinations. You mentioned inclusion of different types of shelters. Will you be recording and reporting separately by each? The needs and public health supports of youth are different than those of older adults. Will you be interviewing, including clients? And is there ethics involvement in some way for this project?
These are really very important questions. I will just say overarching, we don't, at the National Collaborating Centers, we don't do primary research. So this is not a research project. This is about connecting public health to the information and the evidence that they need. And in this case, as you've heard, so much of it was personal experience, the knowledge that the shelter experts have, and those who in public health who are already connected with them. And then we had the really wonderful addition of or the component of the rapid review from what there is in the research. So what somebody else has done in their research or their program evaluation. The question is, will you be recording and reporting separately from each of the different kinds of shelters? Not as such. I think we're thinking it a bit more holistically, but as Adina said, in thinking about what are our next steps, connecting folks to each other if they're running the same kind of facility might be very important for them. So we will wait to hear from them, when we start to plan some next gatherings, be they online or in person. What do you need? What will strengthen the work that you do? Where are the connections you need for your clients? So all to say that ethics will come up in the way that we approach the work, but might not be in terms of a formal academic ethics submission because we're not doing research as such.
Thanks for that clarification, Margaret. We also have a comment from Dana, and Dana has a comment around barriers and follow up to that conversation. And Dana says, we currently have a pilot project between public health, primary healthcare, and mental health and addictions, running a bi-weekly clinic at our local shelter. We are still trying to address any barriers that have been brought to our attention, but are still not getting many folks in. Out of the list of different topics, approaches you listed in the beginning, was there any that were most successful or any general information about reaching the population? Great question. Thanks, Dana.
So maybe I'll jump in on that in terms of what we saw in the scoping review. And, for more on this, I would suggest that you actually look at the scoping review and you can look at some of those, look at the actual publications, because some of them were fairly informative, I would say, about the way that their partnership operated or the way that their service happened. We didn't, because it was a scoping review, we didn't assess the effectiveness of particular interventions. So I can't tell you that one of, a certain model was sort of better as a model than another. But I can say that those examples that had more of that sort of multiple partner, including individuals experiencing houselessness, as part of the deliberations, seem to have more staying power. So, they were the ones that were able to do multiple things, sort of move with the times, as opposed to those examples that were, we showed up, we did a dental health assessment, and, then after that, people knew that they had dental problems, which they probably knew already, so superficial level, anyway, I can say that those projects that gave time to the partnership was needed and how to do it, I would say had more likelihood of stability and sort of ongoingness, just because of that. But there may be some specific examples that might be of interest for you in the review.
Thanks, Susan. And this what Elena, she just provided the access to the full review in the chat if you'd like to take a look. And I think we have one more time for one more question from Deborah. Was there discussion about the role of public health regarding policy development versus more immediate issues such as infection control? If yes, what were shelter's opinions of such policy?
Great question. Thanks. Yes, I think maybe I'll jump in to start, and feel free to Margaret and Susan to add to it. Yes. Can you just sort of, I was listening, so would you mind repeating the question just to make sure that I answer it?
Sure.
Yeah.
So was there discussion about the role of public health regarding policy development versus more immediate needs issues like infection control? If yes, what were shelter's opinions of policy?
Certainly it came up, quite a bit in all the engagements, both with shelters and public health and at the Institute, sort of around sort of a broader scope of what public health can work with shelters, and sort of a lot of the work tended to be more task oriented, and sort of really there was shelters talked about sort of the benefit when they've had to been able to, as Susan said, like a longer relationship, a relationship that wasn't maybe as focused on sort of contract tracing or a specific outbreak management or something like that, when it could have been sort of more the health promotion, which I would say is sort of also connected to this concept of policy and sort of looking at broader health needs and broader engagement. As well, in particular, policy did come up quite a bit at the Institute, in terms of what role could public health play in sort of a number of different levels, in terms of like houselessness prevention on a municipal level, on a community level, what kind of policies in terms of access to healthcare, as in terms of coming from specifically the shelters. Shelters were talking about sort of exploring the nuance of what harm reduction policies might look like at their shelters, and how to sort of explore the different needs of different community members, and sort of so that there was some talk about some support around harm reduction policies, as well as some support around trauma-informed care and exploring that approach to care. But I mean, often sort of, and also, shelters leadership and staff were also talking about sort of the challenges of time to sort of explore policies and to look at policies, and to sort of work in that framework when the day-to-day demands are so high. So even sort of some space and place to have some of those discussions and those explorations. Margaret or Susan, anything that you'd like to add?
No, thanks. I think that was a great summary of what we heard, Adina. Thank you.
Great. So I would just like to say thank you so much to Susan, Adina, and Margaret for sharing your experience, your knowledge. And I know I'm so excited to hear about future and next steps and see this evolving work. So thank you so much for your time.
It was a real pleasure. You'll see the post-webinar poll coming up if you can take just a couple of seconds to give us some feedback. But a real pleasure for NCCMT to be here today and to participate in this broader work that NCCID is doing. So thank you, Miigwech.
And thank you, everybody. All the presentations from the Winter Institute will be available very shortly online through our website, which is here. And thanks for taking part today.
Bye, everyone. Take care.
Thank you all. Bye for now.